Hi guys, so we just talked about the thyroid problems that go with the endocrine system, and now we're going to try and talk about the adrenal system, the adrenal gland issues. There's four major disorders that we're going to be talking about: Addison's, Cushing's, hyperaldosteronism, and pheochromocytoma. So let's go back to our little drawing here. So in this case, our hypothalamus is going to be sending hormones to the pituitary, and this time the pituitary is going to be secreting a hormone called ACTH, and that's going to be secreting it to the adrenal gland. The adrenal gland has two major portions. It has the cortex, which is the outside, and the medulla, which is the inside. And both parts secrete different hormones. So we have the medulla, which is the inside, and that's going to be secreting our catecholamines. And our catecholamines are hormones like epinephrine, norepinephrine, and dopamine. So, epinephrine, norepinephrine, and dopamine. Then, on the other side, we have the cortex. And like I said, that's the outside. And this cortex secretes three major groups of hormones. So we have the three S's. S, S, S. Sugar, salt, and sex. Our sugar hormones are the glucocorticoids, and an example of those are cortisol. Our salt hormones are the mineral corticoids, I believe, and the example for those is aldosterone. And then our sex hormones are androgens. Alright, and I can make another video separate for the way aldosterone works, just in case you don't remember how the renin-angiotensin-aldosterone system works. I can do that later, but for now we'll just stick to our basic disorders. Okay, so let's start with Addison's disease. So, what Addison's disease is basically an autoimmune attack of our adrenal gland. So, there's an attack of our adrenal gland, which means that there is no output of any of these hormones. We have a decreased output of these hormones because the adrenal gland is damaged. So, we're going to see a decrease in cortisol, we're going to see a decrease in aldosterone, and we're going to see a decrease in androgens. And that's where all of our side effects are coming from. We're going to have, because we have a decrease in all of our catecholamines, we're going to see a decrease in blood pressure. We're going to see, because of our decreased aldosterone, we're going to see increased potassium level. We're going to see or increased sodium level and decreased potassium level. No, that's not right. Increased potassium, decreased sodium. We're going to see a decrease in our blood sugar. We're going to see darkening of our skin, our knuckles, our elbows, some weakness and fatigue. You might see some mouth lesions, vomiting, and diarrhea. If these patients come under stress, they have no way to deal with that stress physiologically because of the decrease in these hormones. So they'll go into something called Addisonian crisis. And like I said, that can be caused by anything like trauma, stress, steroid withdrawal, if we stop taking our glucocorticoids the way we're supposed to be taking them. So some things that we might see in an Addisonian crisis are decreased BP, vomiting, diarrhea, confusion, fever, tachycardia, weakness. It's your body trying to fight that stress, but it can't. Some diagnostic tests, they might do an early morning ACTH level, and if we think about this, this works just like your thyroid system, in that there's a negative feedback system. There's a negative feedback system. So if there's too much of these hormones, it's going to tell the hypothalamus and the pituitary to stop secreting ACTH, which will stop secreting these hormones. But if there's too much, not enough of them, your body's going to say, hypothalamus and pituitary, get your butt in here and increase your ACTH levels, which is why in these Addison's patients who aren't secreting enough of these hormones, there's going to be an increased ACTH. So they might also look for, like I said before, there's going to be a decreased blood sugar in these patients, an increased potassium, and an increase of your WBCs. Because if your body's attacking your adrenal gland, that you're going to have increased WBCs. So some ways to manage Addison's disease, we can give corticosteroids to replace these steroids that are missing. We might be able to give antibiotics, vasopressors, because what are vasopressors going to do? They're going to increase your blood pressure. So because these patients have decreased blood pressure, we might treat them with vasopressors. And we also, because of their low blood sugar, would like to give them D5-NSS. So, our nursing interventions for Addison's are basically, we want to combat circulatory shock by restoring blood circulation. So we want to administer fluids, and we want to put our patients in a recumbent position. So we want to lay them back. We don't want them getting stressed. We don't want them, having their body having to work hard, because, like I said, they have decreased ability to fight that stress. And we want to monitor their fluid balance. We might want them to increase their salt levels because they have decreased sodium, and increasing their salt might increase their blood pressure. So the next thing we're going to talk about is Cushing's. And one of the major things that causes Cushing's is a tumor of the pituitary gland that increases the production of ACTH. So we have a tumor of our pituitary gland, which is causing Cushing's. And increasing our ACTH production. So if we are increasing our ACTH, our body is telling the adrenal gland to make more of all of these hormones. Okay? So, it could be caused by pituitary a tumor of the pituitary, but it can also be caused by too much use of corticosteroids, so long-term corticosteroid treatment. Basically, what kind of symptoms are we going to see? We're going to see moon face. We're going to see masculinized female faces because we're having those androgens pumped out. We're going to see some truncal obesity. We're going to see thin extremities from muscle withering and wasting. We might see some striae, some stretch marks on their abdomen, because remember they're having that truncal obesity. We might see a buffalo hump on their back, and breast tissue atrophy. Let's see. some of the ways we would test for Cushing's disease is the dexamethasone screening test. So what you do is you give the dexamethasone to the patient in the evening, and if in the morning your cortisol levels are high, you're positive for Cushing's. You can read the book about how it works. I'm not going to go into that right now because honestly I think as long as you know that in the morning your cortisol levels are still high, you'll be okay for the exam. So high cortisol levels in the morning equal positive for Cushing's. They may treat this with radiation of the pituitary, because remember the pituitary is the problem in this case. They may also do a surgical intervention called the transsphenoidal hyperphyseectomy, so they're going to go through the nose and take out that tumor on the pituitary. We want to, if we do either of these things, be really careful because we want to make sure that they don't start going into adrenal insufficiency. So if we take away that tumor that's causing all these ACTH problems, we might end up dropping them into adrenal insufficiency. We want to decrease their risk for injury and infection because we have if we're treating them with, I believe that is because you're treating them with corticosteroids, which bring you at more risk for infection. And also, if you have high cortisol levels to begin with, you might be at more risk for infection. I think that's the case. Look that up. I could be wrong. We want to give them foods high in protein, high in calcium, and vitamin D to minimize that muscle wasting that I was talking about earlier, the thin extremities, and the osteoporosis that goes along with this disorder. Two more disorders. We have the hyperaldosteronism, which is going right here with this portion, and my marker is going away here. With this aldosterone portion here, you're going to have increased levels of aldosterone, and this is called hyperaldosteronism. Okay, so I can make another video if I need to, but we know that aldosterone causes the body to hold in all of the sodium, and it makes you hold on to all your volume. So you're going to be hypervolemic. You may or may not have high sodium levels. It could be normal, they could be high. You're going to have hypertension because you have all that fluid being held in you. You're going to have decreased potassium because of that fluid as well. So our two major things that we want to think about with this disease are hypertension and hypokalemia, low potassium. Some other symptoms that we might see are headache, muscle weakness because of the hypokalemia, some numbness, paralysis, decreased bowel motility, dysrhythmias, all to do with that hypervolemia and hypokalemia, so everything that goes with that. In your notes, you might see something that talks about having urinating a lot, excess urination, and what I've read about that, although honestly it's kind of confusing to me, is that if you have hypokalemia, your kidneys are not able to concentrate your urine, so you're going to be urinating a lot of fluid. So here we are with it seems kind of counterintuitive because you have this disorder where you're holding on to all this volume, but if your the potassium level gets low enough, you start excreting all this urine. And I wouldn't get too caught up on that. You can see that in the notes, you can read about it in the book, but that's what's happening. Hypokalemia can lead to decreased concentration of your urine and excess urination. Something that they can do for this hyperaldosteronism is they can do an adrenalectomy. So they're going to be taking the, removing the adrenal gland. And we've got to think there's got to be consequences to that. You're not going to be getting all these hormones, so you're obviously going to be having to do replacement hormones post-procedure, corticosteroids and such. You need to make sure that before the adrenalectomy that you get your BP under control, like Tracy was talking about in class, that they have the blood volume under control. You need to hydrate them to make sure they're not hypovolemic. You need, and like I said before, you need to be careful that they're not going to drop in these hormones and then have issues. One thing that can happen with the adrenalectomy is that stored epinephrine and norepinephrine in the medulla can be released during the procedure and cause problems. Think about what epinephrine and norepinephrine are doing for the body. We don't want too much of that. And some nursing interventions, we want to maintain the cardiac output. We want to make sure they're putting enough blood out into the system, prevent renal complications, monitor for hypertensive crisis, and monitor serum electrolytes. And last but not least, we're finally almost there, we have pheochromocytoma. And basically what's happening with this is we have a tumor on our adrenal gland, which is causing an increased catecholamine response. So we are getting too much catecholamines with this epinephrine and the norepinephrine. And our 5 major manifestations with this disorder, and I would know these for the exam, are the 5 H's: hypertension, headache, hyperhidrosis, which means you're sweating a lot, hypermetabolism, and hyperglycemia, so increased blood sugar, and that's because of the increased epinephrine that we're getting from the pheochromocytoma. So some ways that we know that a patient might have pheochromocytoma is one of them is called the clonidine suppression test, and basically we're going to give, we're going to see if we can suppress the release of catecholamines, and if they are not suppressed, we know that they might have pheochromocytoma because it's the normal mechanism for catecholamine release is being bypassed. I don't think she'll ask too much about that, but just it's in your book if you want to get more into that. The other thing that you might do for this patient is that you will take a 24-hour urine test, and we're looking for these high level of catecholamines because, like I said, this is a tumor on the adrenal gland that causes excess secretion of catecholamines, so we're going to be looking for those high catecholamine levels. When you're taking that 24-hour urine test, you want to tell your patient not to be drinking any caffeine, no coffee, no tea. You don't want to have them eat bananas or chocolate or vanilla or any kind of aspirin product because it may interfere with the catecholamine release, and we don't want that. The major group of medications that we're going to be giving these patients are beta blockers. They slow the heart rate, make the heart more effective. Adrenalectomy is also an option for here. We're going to remove that tumor from the adrenal gland, which will reduce the issues with the excess epinephrine and norepinephrine release. Pre-op, again, with the adrenalectomy, we want to control that BP. We want to keep them hydrated. And we want to make sure they have their corticosteroids. Post-op, they're going to be in the ICU. We want to monitor their heart with an ECG. Like I said before, monitor their fluids, monitor their electrolytes, and also because they may drop in their glucose levels once we take that adrenal tumor away, because remember, they're having hyperglycemia before, they may have hypoglycemia after. So we want to keep track of that. Some teaching, we want to teach them to avoid anything that could cause hypertension. Water, we want to make sure they're having a lot of fiber so they're not having strain to go to the bathroom, and we want them to keep exercising, stay healthy, keep a normal diet. I think that's everything. I hope I didn't mess up too much, and I hope that I helped you understand a little bit more about these disorders. Anyway, good luck studying, guys. See you next week.